So thank you very much for joining us. A quick agenda for what we're going to do. I will spend a couple minutes at the beginning just to explain to you what the forum is, what our Queen Elizabeth Scholarship Program is, and then I'll introduce you to each of our 4 presenters, all of whom traveled abroad in the fall and had wonderful experiences, which you'll hear about today. We will then do questions for everyone, so we'll do the question period at the end of all 4 of their presentations. And then once that's finished, I'm going to tell you a little bit about our new Queen Elizabeth Scholarship Program, and then we'll move into the other room and have some refreshments, and you'll have a chance to ask our scholars questions about their experiences further. So come on in, have a seat, and we'll get started. So the McMaster Health Forum is the leading hub for improving health outcomes through collective problem solving. We aim to harness information, convene stakeholders, and prepare action-oriented leaders, and work as an agent of change by empowering stakeholders. The Queen Elizabeth Scholarship Program is run by a partnership between the Rita Hall Foundation, Community Foundations of Canada, Universities Canada, and Canadian universities. The purpose is to activate a dynamic community of young global leaders across the Commonwealth to create lasting impacts both at home and abroad through cross-cultural exchanges encompassing international education, discovery and inquiry, and professional experiences. Here at the forum, our Queen Elizabeth Scholarship Program is called Strengthening Health Systems. Our scholars will contribute to strengthening health systems and become part of our large and growing network of health systems leaders. We have had 3 cohorts of scholars so far. Here is the list of our first group of scholars who went abroad or visited us primarily in the calendar year of 2016. We saw an influx of applications after that first group, and so here's our second group of cohort, our second cohort, which was in 2017. Our 4 presenters today come from this cohort. And our last cohort in this particular Queen Elizabeth Scholarship Program is cohort number 3. We have a number of incoming scholars who will be visiting us in the summer, and then mainly undergraduates who will be traveling in the summer and or the fall this year to conclude this version of the Queen Elizabeth Scholarship Program here at the McMaster Health Forum. We'll introduce you to Tahmina, who is also an undergraduate in the Bachelor of Health Sciences programs specializing in global health. She has always had an interest in the macro approach to health and how various actors within the system come about to impact change via policy reform. Tahmina interned with the National Health Service in England, where she hopes to better understand the role of innovation and producing better value for a health system. So we'll find out if she was successful in that. Tahmina.
Thank you. Thank you. Thanks, James. Yeah, people can hear me. So, as James mentioned, I was at the NHS in England, although it's not, the NHS isn't really a thing, which is one of the first things I learned. But a little bit about kind of my work and what I did. Initially, I went in thinking I was going to do an entirely different project. So the NHS has something called the test bed program, where they are able to kind of test new innovations in conjunction with one another. So, for instance, if you have a disease pathway like cardiovascular disease, you'll have multiple kind of interventions and technologies that can address that. And what the test beds program does is it allows all of those technologies to come in and test together to understand not how they would work in isolation, but rather how they would work together and how that impacts like the daily workflow of a clinician or a nurse or whoever is working wherever in that program. So that's what I thought I was going to do. And then I got there, and my supervisor, Kathy Scott, absolutely amazing woman, said, no, that's not what you're going to be doing. There's a minister, and he's got kind of this vision that he wants to understand better. And so as part of the 5 years forward view, the NHS, which put out that document that kind of laid out what they wanted the NHS to look like in 5 years and kind of the steps, the goals they wanted to meet in order to make it a better system. And part of that was making it easier for health innovations to get uptake into the NHS. But the problem was that the NHS England, they knew very little about kind of what the pipeline from ideation to uptake actually looks like for health technology and where the challenges exist for innovators in getting their product created, tested, developed, validated, uptaken, all of that kind of stuff. So my job was trying to understand this very, very complex system that went across different organizations, not just NHS England, but other things like the NIHR, which is the National Institute for Health Research, or the Wellcome Trust, or private industry as well. And basically what I did was I collected quantitative and qualitative data, and then I analyzed the data and I had to understand kind of where the gaps, redundancies, and opportunities for strengthening existed. That should say, what are we even talking about? But that's fine. One of the challenges that existed for me in this role was this isn't a traditional research environment. This wasn't academia. This was kind of a government adjacent office, really, is what it was. And so they just told me, we want to know how are innovators being supported in kind of the innovation landscape. And that was it. I didn't get any kind of background on what that meant, what the innovation system looked like, what support even meant. And so for me, so much of the challenge was trying to identify, like, what are we even talking about when we say we want to understand the innovation landscape, we want to understand support, what does support look like? And that was some of the biggest challenges, which I highlighted here. I mean, and that was just a process of kind of having conversations with innovators, with policymakers, with clinicians, and all of these different kind of actors in the system. What did support in their mind look like, and kind of collating that and developing something that was a little more consistent that I could use to then collect data about. And the types of support were kind of like funding, infrastructure, brokering, collaboration, a testing environment, training. What did the pathway look like? This was interesting because I worked in Toronto at the Mars Discovery District in the Excellence for Clinical Innovation and Technology Evaluation program, and we had one model of what the innovation development pathway looked like, and I came to the UK and they're like, no, this is what it actually looks like, and I had to develop kind of a different model for that. And again, that's like idea, research, prototype development, proof of concept, clinical evidence, and then finally adoption and spread. This is just kind of an example of the types of data analysis I'm talking about. So it was a lot of quantitative understanding, kind of what are all the supports that out there that are available, what do they look like, and who do they support, and then developing graphs like this to get a better understanding visually. So you can see here, obviously, that there's a lot of support for industry, small, medium-sized enterprises, and less so for, say, clinicians, for instance. If they had an innovation, they wanted support for that. I think I can't talk too much about it because it is something that was confidential. But in terms of the work that I did, like I said, the first thing I realized was that there's no such thing as the NHS, really. There's a few arm's length bodies. There's about 15 of them, and they work together to kind of comprise of what we think of when we think of the NHS and the health system in the UK. And the NHS kind of title was retired in favor of NHS England, NHS Scotland, and each kind of country in the UK having their own kind of name. But I realized how complicated and massive it is. I think if people have taken health pol, you kind of start to understand what the Ontario health system is like, and you're like, oh, this is like, I think I can understand this. When I got to the UK, I didn't understand anything, and I asked people, and they're like, you know what, we don't really understand this so much either, because it's so much older than the Ontario healthcare system is, and also there everything's publicly paid for, but also publicly provided, which presents this new set of kind of challenges, which goes to the next one. I learned about some of the kind of unique challenges that exist in decentralizing and centralizing. So the NHS had a history of being very centralized, and there's a lot of criticism and feedback and research that went, and they thought, no, we should be decentralizing. We should be giving kind of individual clinical commissioning groups more power to be able to carry out their day-to-day tasks however they see fit, in a kind of a local context. And they did that, and they got feedback saying, no, that was the wrong thing to do. You need to backtrack a little bit, and maybe we need it to be a little more centralized, because now the issue is that in some, areas covered by a clinical commissioning group, there'll be an intervention that's covered publicly, and in another there won't be, just because of the individual decision-making power that these groups kind of have. And so then you have gaps, and it no longer becomes a universal system because the decision-making is so decentralized. And again, that question that I had was, is there a happy medium, or do we accept some challenges over the other? And that's not something I was able to quickly answer, but it is something that I was thinking about the entire time that I was there, especially because I think in the news we hear so much about the NHS, and I mean, right now they're having a lot of issues with, there's a huge gap where there's billions of dollars of services that are needed that the NHS can't provide because there simply isn't the money. And so they're always asking themselves, being in that organization, I could see that even on an individual level, you know, people working in these offices are asking the exact same big questions that people in government and researchers and the news is asking, which is how can we make it a better system? And there aren't any easy answers. Kind of the third thing is health innovation is kind of a burgeoning focus of interest for a lot of health systems around the world, right? And health systems design is kind of, people talk about it a lot, and it's become almost like a buzzword. And I think there's a lot of value in understanding, you know, the world is changing, and technology has such an important role in all of our in all of the facets of life. And of course that includes healthcare. But I think one of the biggest things that I learned being immersed in it in Toronto and then again in Leeds is that sometimes the answer isn't always more technology. I think there's always this reaction to be like, oh, there's this cool new tech and it's going to solve X problem. Let's just kind of throw it at the problem, pay for it, fund it. That's not really how it works a lot of the time. Sometimes the issue isn't necessarily that there isn't a technology that can do a specific thing. It's more so about what does the culture around that problem look like, and how do we address that, and how do we address kind of the individual actors who are working to fix the problem rather than just throwing more technology at it, if that makes sense. Which leads to the final one, which is that all the innovative technologies and policies in the world won't make a difference without uptake. I think, especially coming from an academic background, you get so excited and you read all these cool papers and you think, oh wow, like, you know, there's this cool new way to do something and it's going to solve everything because there's so much evidence that says it will. But if you don't have implementation, if you don't have the community itself, if you don't have the clinicians kind of willing to adopt this into their daily workflow, you're not going to get any change. Like, it's just not going to change anything. And I think as part of my work collecting qualitative data, I got to talk to healthcare innovators, so people who had developed some kind of technology and in one way or another had touched kind of the health system, either earlier in the ideation process or maybe later in the uptake process. One of them that I talked to, they said that 10% of the challenge was developing that technology. It was kind of figuring out what the problem was, figuring out what are the technical components that are going to go into whatever it is that they were going to create to address the problem. That was only 10% of the issue for them. The other kind of 90% was getting someone to just take their technology and use it. And it's definitely not an insignificant problem. I think the NHS has multiple programs to encourage uptake of innovations. For instance, there's a program that basically funds it. If the hospital wants to try out a new piece of technology in their hospital, the NHS will kind of cover it from a separate budget that doesn't affect the hospital's regular kind of global budget. And despite that, and despite the fact that they will also kind of provide the personnel support to go in and to help the hospital uptake this technology, hospital administrators still say no. They're like, no, we'll pass. And you know, the innovator will be like, no, but we have this great body of knowledge that says this will, you know, completely decrease or eliminate this problem that you're having in the hospital, and still the answer is no. And that goes back to this question of, there's a culture kind of at play. There's always a culture at play. There's always people and their personal interests and their kind of personal issues. And if you don't address that, if you don't kind of work to talk with them and, you know, kind of get them into the decision making early on, you're not just going to be able to walk in and say, here's a piece of technology, use it. They're going to say no, even if it's, you know, we know objectively the evidence is that it works. You know, it's just so much more than having the technology. I think implementation for me was understanding that implementation is part of the most important part of kind of policy. In terms of lessons learned in life, so I kind of learned to be open to new experiences. At where I was working, which is the Innovation Research Unit of the NHS England, I had the opportunity to go to a lot of conferences, a lot of talks, a lot of kind of events, and I had a lot of support to do that, but at first I was hesitant. You know, I didn't want to travel all the way into London by myself and go to this event by myself without kind of having my supervisor to be there with me, especially because a lot of these events were geared towards high-level kind of ministers and policymakers, and I felt like I'd be out of place. But eventually I took her up on some of these offers, and as I entered these spaces, I realized how much I could learn just from being there, and it's not, sorry, it's not always about being able to contribute. Sometimes it's just about, as Jessica was saying, just learning and observing. Not being afraid to ask for help. I mean, with this project, it was a huge undertaking, and I literally had nothing to go on other than we want to understand the system better. And I was like, what system? What are you talking about? And it was starting from scratch and building all that. I wouldn't have been able to if I wasn't I was, unafraid to ask for help. And even the data analysis, some of the quantitative analysis, I was like, I have no idea what I'm doing. I didn't know Excel could even do some of the things that it does. Like, Excel is amazing. That's kind of something I learned. You can process so much data within that spreadsheet, and it'll spit it back at you and give you all these, it's amazing. I didn't know that until I kind of talked to the data analysis team at the NHS, and they sat me down and they taught me some of these things, and I was able to then take it on further and implement it with the work. And then finally, you know more than you think. So when I did this project, I think I had a lot of, again, because it was such a nebulous kind of idea at first, I had a lot of insecurity about, am I even doing this correctly? Like, do I know what I'm doing? Is this going to mean anything to anyone at the end of the day, or is this just a piece of make work where I leave it, it gets shelved, and it doesn't do anything? But luckily, I left, right, feeling kind of a little more confident. But after I did leave, I got an email one day from my supervisor at the NHS, and she said, we showed your report to the minister who asked for it, and now it's kind of like making its rounds at the House of Lords, and everyone's really interested and excited, and now they know where to kind of take some of their projects forward because of the data and the analysis that you had done in your report. And I was like, wow, cool. I did something, meaningful and important that's going to make an impact in the decisions that are made out at a national level, which is kind of a cool and neat experience. But yeah, that's kind of it. That was my experience at NHS England.
And we'll open it up now to the room for anybody who has a question.
So this is a suggestion from my father. He said because I didn't really understand the country as well, he said, okay, so book a place for like a week or 2 weeks because then you have some place to stay. And then before you make the 3-month commitment, for example, go ask around, learn about the areas, and then based on that, you should make your commitment. And I think that was a good idea because I actually changed houses 3 times within the first week. And I'm really glad I did that because the third house I found, I stayed for 2.5 months, and it was probably the best choice. So I would also recommend that too. Very good question, Puru. So in terms of just adjusting to that, I think first off, I'd like to highlight that everyone is very, very friendly, and they do have a really human side of them. So it was really easy to connect when they were cracking jokes about having cookies or just eating a lot, etc. Like, it was a very common joke because in Cape Town they eat a lot. So first, just recognizing that you're a student and the fact that they also recognize that you don't know everything. Aside from that, because there's so many interprofessional meetings, people had different background knowledge, so as a result of that, they did treat me as someone who had a specific objective, so they knew that I was here to discuss my research process, discuss the obstacles I face as well as my point of view, and work alongside them. So viewing myself as a team member, someone with different skills was one way to accommodate, and also just knowing that because, as others have mentioned, we are there to learn as well, but also contribute, asking a lot of questions, and showing that we're really engaged in the process, as well, the fact that I did all the time to do my research just shows that I was involved, and it helped me become more comfortable. So it was just it's something that you will only know once you actually dive in, for example, yeah.
Yeah, for sure. I think the one that comes to mind immediately was in Broken Hill. So I guess one of the reasons actually that Broken Hill was chosen as a community was that it does have one of the highest Aboriginal Australian populations there. And so it was definitely, like, I was able to see this disparity between the types of services or even like the way in which the town looked compared it to perhaps like Albany, which was a coastal town. They had a history of like whaling, things like that, so they had a little bit, I guess the financial situation was a little bit different as well. And so I could definitely see that contrast. And then even in my own like personal travels, obviously up to like Sydney and like the Gold Coast as well, which is another community that we were working with. Like I could see the ways in which being more rural or more remote, kind of like in Canada as well, it can lead to certain like inequities in terms of the resources or funding that you can access. And I was especially interested, I guess, in looking into that difference between the Aboriginal Australian population and the larger Australian population. And so that was kind of prevalent, especially when I went into the more rural or remote communities. So,
I think for me, my biggest asset was kind of actually my ignorance because I didn't come in with any preconceived notions about what things should look like or how things should be. So much of my work before kind of making recommendations, which is part of the work that I did, but so much of it was just characterizing the landscape, and I did that with a fresh set of eyes, and I think that a lot of people who were kind of looking at my work were noticing that I was picking up on things that they had always glossed over because they were just so familiar with it. I was able to look at it in a more critical lens, and I think that was valuable because of the work that I was doing specifically.
Yeah, I would say for me, literally like my time, I guess, like my effort, because the way this project was so fast-paced. When I went there, I was thrown into the middle of this data collection meeting, and I was so lost, and like we were moving so fast through all the different communities, like, and this was a component of work, this literature review that they needed to have done, but there wasn't really anyone to do it. So I think that was like an asset I brought, is that, I guess, that ability to contribute to the team and like do something meaningful, as you were saying. Like, this is a piece of work that they needed and they wanted, they just didn't have the time to do it. So I guess that would be something that I brought.
Yeah, similar to Tahmina, I would say just this ability to ask questions, coming in from, again, like a fresh pair of eyes. And for me, what they found really interesting was that they had no idea that I worked on like a health tech startup, and I'd sort of brought in my understanding of like software, and I was like, hey, what you're studying is actually a lot like this thing in business. And they were like, we did not know that. So it was just this idea that you're coming in with your own unique background, and you can point things out and ask questions that they wouldn't necessarily have thought of otherwise. So it's just another diverse person to the mix. When I describe, like, I've tried to describe like what I brought in from other things, and I think it's really not about necessarily content knowledge, but about really just this ability that you come in with to be able to find that information. So the skills you've built up over the last couple of years of undergrad in finding information and taking initiative and sort of confronting those challenges and asking for help are probably going to take you much further than a particular course in the program will.
Yeah, I just want to really kind of reiterate and reinforce that the inquiry process and learning how to ask questions, that shouldn't be understated. You would be surprised at how many people don't know how to ask good questions and don't know how to find answers to them. And it's not about knowing things, but about being able to get to answers, and having kind of those strong research skills. And I don't mean like wet lab research or anything like that, but I mean kind of critical thinking, critical analysis, being able to analyze a piece of literature and understand what it's really saying versus what it thinks it's saying, and that kind of stuff. And all of that, I mean, critical crap, for instance, health Paul, all of those courses kind of teach us those things. So I think, was it Jessica actually kind of, was it you? Sims, actually, this idea of co-design. So I think in the work that I'm doing kind of like in health of innovation, both in Toronto and then that I kind of did in Leeds as well. Co-design is this idea that the people that are going to build the solutions and the people that are actually going to use them and be the people who are kind of maybe part of the problem, not like the problem that is, and maybe they have that health issue or whatever, they're all together in kind of the ideation phases to talk to each other, to communicate, to understand like what do we want this to look like realistically. When they're left out of that decision-making kind of process in the early stages, that's where some of the implementation issues come in, because when it comes time to implement this, because the clinicians were not there and it was just maybe a bunch of researchers and some I don't know, engineers, they can't foresee certain things, right? And having those perspectives are really important in being able to catch them early on, implement them into the design of whatever it is you're working on, whether it's a policy or a piece of technology, and then that addresses kind of some of the issues that come later down the road.
I guess having a policy window or or political and social environment that is conducive to results, it really helps push the process forward. And just to re-highlight, engaging multiple perspectives, having certain deadlines, and something to really push forward the implementation, I think really helps. So for in my case, we were so limited on funding and because there's no specific committee, it's really hard to implement and push things forward. I think that's where like the policy window or having some sort of impetus would be really useful as well.
I mean, I think with me, so like in terms of scale, like we don't have like a Canadian health system, right? We have the Ontario health system, and the Ontario health system is so much smaller than the NHS. It's just in terms of the number of people working in it, but also the resources and funding available. But I think coming back from the NHS and seeing how, I mean, there's always this joke that the NHS is behind because they're just kind of like this big lumbering organization and they think they're not innovative. I thought they were actually really innovative, and I came back and I kind of took that back to my team in Toronto, and I was like, oh, they're implementing like these types of programs. They have this kind of government support that just doesn't exist here, and everyone was a little shocked. Like they didn't realize that that was the case, and I think that we do have a lot to learn from them in terms of the way that they go about funding and supporting health innovators, which I know is like a very specific thing that not everyone's interested in, but that was something that I took away, realizing that they were a lot further ahead than we were, but just because we're kind of newer and shinier, people think that's not the case.
So I'm cognizant of the time, so I'm going to draw it to a close, and I want to thank all of our scholars again for their presentation. So give them your appreciation. To today's session. That first link that's on the screen right now is the link to our scholarship page. So when we do update it and we announce the application window, that's where you can find it. We will continue to have webinars. So we are at the end of the webinars for the second cohort, but of course our third cohort, all of those students will be conducting webinars in the future when they come back. So look for a series of webinars in the fall, and they also all write blog posts. So all of them write a blog that is posted on that third link, the MacHealthForumScholars.com website has blogs from all of our scholars back to the first cohort. Gives you an idea of the more personal side of things. And all of the scholars that you saw today will have a blog post there as we go along. So thank you for coming.